Good evening. I'm Elizabeth Bennion. I am a professor of political science and campus director of the American Democracy Project here at Indiana University South Bend. And we are very pleased to partner with the MPA Student Association on this important event entitled Community Forum, the Opioid Epidemic in Michiana. What we've tried to do for this evening is to bring you a panel of people who have a diverse range of perspectives and experiences related to this issue. And we've asked them each to speak for about 3 to 5 minutes on the topic of a few takeaway points that they think are critical for you to know as you think about this particular social issue or crisis. After they speak, there will be time for Q&A, and those questions will come from you. You should have received a note card. If you need a pencil or a note card, you can raise your hand and some of our volunteers will get those to you. If you have a note card that's ready, just pass it down to the end of the aisle. Somebody will collect that. They'll bring those to Dr. Gallagher. Dr. Gallagher is a researcher who studies this issue as well as a therapist and a professor here at IU South Bend, and he'll be moderating that Q&A portion as somebody who brings an expertise and experience with this particular issue that I do not. So I'm delighted that he agreed to do that for us today. We're so glad to see you here. The panelists will be able to announce themselves. They can tell you more who they are, but we do want to make sure there's plenty of time for your questions. So before we get started with our panel, I just want to take a minute to welcome our sheriff in St. Joseph County, Sheriff Bill Redman.
Thank you, Dr. Bennion. I was asked to come and just welcome everybody, so welcome. I appreciate everybody being in attendance today. This is certainly an important issue. I would like everybody to know that I, as the sheriff, and our St. Joe County Police Department is committed to helping in any way we can to stop this opioid epidemic. I have worked with many people here as part of the panel and continue to do so in the future. But I want everybody to know that we are committed to helping in any way we can to stop the opioid issue and also to provide treatment and assistance to those individuals who are in need. We partnered recently with Victory Clinic. We received a $75,000 grant to partnership with the Victory Clinic. We've done some work specifically with Oaklawn, and we will continue to do that and commit to assisting them in any way we can. Of course, the prosecutor and I have worked well together thus far. Today's my 100th day in office, so we've done a lot of good things in a short period of time. Alicia and myself have partnered and will be continuing to do some positive things here in our community. So welcome everybody. Thank you for being here and taking the initiative to fight this epidemic that we have here in our community. And let's all continue to work together. Thank you.
Okay, we are going to have our panelists share their remarks, but one of the things that you will notice on your program is not only do we have panelist bios, but we also have information about the breakout sessions. And all of our panelists have agreed to participate in those special breakout sessions later this evening. And you can pick 2 of those topics: effects on addicts and families, new directions in law enforcement, best practices in treatment and recovery, medical treatment, and public health solutions. And you'll be able to pick 2 of those. They'll be quick, 20 minutes, so that's an opportunity to talk more with our panelists. And now for a quick issue overview, I want to introduce you to Dr. John Gallagher.
First I'd like to say I'm honored to be here, and this community forum is part of the solution. So we have the experts up here today who will share their range of expertise, but you all, students, community members, you are part of this solution as well. And so I encourage you, to share your experiences with us, don't be cautious in the questions that you want to ask. Be candid with us, that we can have a dialogue, because I believe that civil dialogue is part of the solution to this epidemic. And so I really am honored. I thank the students and Elizabeth and others for having me here today. I want to spend just a few moments talking about the issue of the opioid epidemic. My colleagues and I, some of them on the panel, we recently wrote a journal article for Alcoholism Treatment Quarterly. It's a pretty well-respected addiction journal. And we talked about 5 interventions that we have been using in the Michiana area to combat the opioid epidemic. This article and what we are doing here in our community has gained international attention, and our community is viewed as a model in using interventions to combat this problem. Now, we certainly have more progress to make, of course, but we are proud of the work that we have done, and we are happy to share that with you. And again, we want to hear your experiences, your thoughts, and your questions to continue moving forward in addressing this problem. The 5 interventions that I'll just identify at this point, our panelists will go into great detail throughout today. The first is we have incorporated recovery coaches into the emergency room at Memorial Hospital, and we hope to expand to other emergency rooms. The second intervention that we have done in this area is we are giving Vivitrol, which is a medication-assisted treatment. You'll learn all about it throughout this evening. To treat opioid use disorders, we deliver Vivitrol in the St. Joseph County Jail. Third, we're using other medication-assisted treatments, such as methadone and Suboxone, in the St. Joseph County Drug Court. Fourth, we have made Narcan readily available throughout the community. Narcan is available to folks like myself, who I do addiction counseling at Basher Children's Home and Oaklawn. Certainly addiction therapists and other human service professionals should have Narcan. But we're getting it into the hands of librarians, people who work at restaurants and fast food places like Walmart and Meijer, because these are the places where individuals will use opioids and where an overdose may happen. The fifth intervention that we talk about in the journal article is we've developed harm reduction recovery groups at Oaklawn. And harm reduction is an approach to addiction treatment for someone who's not ready for full abstinence from all drugs and alcohol. It's about meeting people where they're at. These 5 interventions, we feel, have helped minimize the devastating consequences of this epidemic. And if you'd like a copy of it, you can see me or Alyssa, who's at the social work table, and we'll make sure we get you a copy of that. The last point that I'd like to make is the 6th point. The 6th point did not make it into the journal article, right? But perhaps it's the most important. We, as professionals, we, as communities, need to have a paradigm shift in how we view addiction. I believe I've spent almost 20 years doing addiction and mental health counseling, mostly in criminal justice settings. And I believe that we need to move away from tough on crime, war on crime, punishing the drug users, to actually being compassionate on crime. Now, of course, when people initially hear compassionate on crime, they're taken back. I'm probably not going to win any, a public election anytime soon with that slogan, right? Hear me out for just a second. Compassionate on crime. I'm not talking about violent crimes. I'm talking about crimes related to personal drug use. Compassion is what helps people change. Compassion is coupled with accountability. You can be compassionate and hold men and women accountable for their behaviors. You can be compassionate and protect the individual and public safety. I have found that general compassion and kindness, besides all my academic training and my years of experience, kindness is what helps provide an environment for people to say, I need help and I want to change. And I just want to share with you one quote to wrap this up. I'm a researcher. I traveled this country interviewing men and women who are in programs such as drug courts or other criminal justice programs. And I asked them, tell me about the program. What's working for you? What's going well? Where can we improve? And one of the things that I consistently hear from participants in drug court, which is an alternative to incarceration for those that are involved in the criminal justice system, is compassion. And I'm going to read to you one quote of many from a participant I interviewed here in St. Joseph County. And this participant is actually talking about Judge Miller. Unfortunately, she couldn't be with us tonight. But this is her experiences with Judge Miller. I will graduate drug court because I know the judge cares about me. At first, I had to see her every week, and I was annoyed by that because it took up a lot of time. But I now know why they made us do that. She holds us accountable for what we agreed to do. And even when I was on sanctions for a positive drug test, she didn't yell at me or make me feel bad. She talked to me like I was a real person with a real addiction. I think more people would do better in the justice system if they saw their judges more frequently and had more judges like the one that I have. That quote is fueled by compassion and kindness. And I want to highlight that as a key solution to solving this epidemic. And I look forward to our discussion. Thank you all very much.
Thank you very much. The reason that Judge Miller cannot be here, much to her own disappointment, is that there is a jury sequestered in a case that she's hearing now, and so she's unable to, in fact, meet and join us this evening. But if folks who are standing would like to find a seat, we do have seats still available, and you should feel free to sort of make your way there so that you can not have sore feet by the end of this evening. So we do have a few seats left, and feel free to squeeze your way on through. Friendly group here. Without further ado, we bring you the panelists' remarks. Panelists, there will be timekeepers in the back who will remind you when you are running short on your time. Those are the number of seconds remaining. All right, we will hear first from Alicia Brown. Yes.
Good evening, my name is Alicia Brown. I'm the founder and president of Fresh Attitudes for New Success. I am also the community outreach coordinator for U.S. Addiction Services. I'm a committee member for Recovering Michiana. I'm a mom to a 6-year-old little boy who is adorable. I'm a recovering addict about to hit 6 years this year from opioids. And I'm a 14-time convicted felon, thanks to the gentleman sitting next to me. It's okay, I thanked him earlier. I want to start with a quote by saying the best parts of me came from the worst parts of my life. That's by Charlie Farley. My addiction started because of a surgery for endometriosis diagnosis and a knee injury because I ran track. I believe if my parents were better educated at the age of 18 about what they were feeling, I would not have been given the first script. I was a college student. I attended here. I was president of Students Against Drunk Driving, but yet I found my way into the criminal justice system because a pill took over my body. I remember the day that I knew I had a problem, but I didn't want to say anything because the stigmas of addiction, even telling your own parents that you think you have a problem. I was flabbergasted. I was scared. Through my incarcerations and jail experiences, when I learned that evidence-based treatment is what got me clean. And I had to spend quite a bit of time. I missed the first 4 years of my son's life because I went away for pills. I'm humbled to be sitting here tonight, and I'm humbled to tell my story, where most people say, "You're really proud?" I am not proud of the mistakes that I made while I was active in my addiction, but I'm proud of who I am today. And I'm proud of the community in which I live in, and I'm proud to represent a group of individuals that have been incarcerated, that come out, and we do recover, we do get clean, and we are productive members of society. And we just want as an addict to be welcomed by you. And sober living isn't scary. Sober living is needed. And the reason why sober living is needed is because it's for like-minded individuals to recover together. It's not a drug house. Excuse the expression, it's not a trap house. It's a house of recovery. And believe it or not, it's happening in many states all around, just not here. So I fight for that, and I advocate for that. I get often asked some questions. Are you better now? Can you promise you won't relapse again? How do you manage your pain? I'm here to tell you that I manage my pain by staying active in my recovery with my support system, who I have to call on a regular basis. There's nothing special about me. I'm not cured. I fight it. But I fight it with excellent support and resources right here in St. Joe County. I do want to say that addiction is not just a disease of a person, it's in the family. And many people in this room tonight know somebody that's been addicted, maybe now or in recovery. And I'm here to tell you that I can't wait to talk to you tonight in the breakout sessions. I'm an open book. You can ask me anything and I will tell you. And I will dive deep into what that looks like with our families. After being home from prison 2 years, I get to say all those fancy things I'm doing at the beginning of my name. And I'm pretty impressed with that, but only because of the people that I surround myself with and my willingness to fight. So I look forward to the questions, and I look forward to meeting you all later this evening. Thank you.
Thank you. And as you're listening to the panelists, if you do have a question, write it on your note card and just either hold it up in the air or pass it on down so that we get that to Dr. Gallagher. We will hear next from Ken Cotter.
Thank you, Professor. Although it's really hard to follow what you just said. Because not only was it heartfelt, but I think that I can talk, but because I have not experienced the experiences that you've had, it's more difficult for me to really understand. But I have to. I'm your St. Joseph County Prosecutor. I am the person that, well, not me individually, but I am the entity that had her go to jail, go to prison, convicted 14 different times until it's something connected. And one of the things that she said I think really resonates with me, and I want to make sure everybody understands, somebody who is an addict doesn't start from day one as with a needle in their arm on a street corner, laying there and people just walking by. They start as an athlete who are prescribed opiates because they're in pain. They start because they've slipped and fallen. They went to the doctor and the doctor prescribed those. I'm not blaming doctors. What I am saying is that not one person starts doing the things that they ultimately do to get themselves in jail, to get themselves involved in the criminal justice system. And that really is, for me, a little bit of a change in my thought process, because I can tell you, about 4 years ago, I thought you commit the crime, you need to do the time.
Yeah, you
And then we've had some tragedies in our community that made me reassess what I thought I knew. And it made me reach out to individuals who are a heck of a lot smarter than me and talk with them about what are we doing, because we are not able to arrest our way out of this problem. Instead, we need to find different ways, and just because it's different doesn't mean it's right, so different effective ways. And one of the most important things that I learned is that, as Professor Gallagher kind of talked about, I kind of like the idea of that, what do you call it, compassionate?
Being compassionate on crime.
Compassionate on crime. And that makes all kinds of sense. And so what we've done in the last 4 years, we've over doubled our drug court. And Dr. Gallagher talked about drug court. Drug court is an alternative to getting a conviction and an alternative to going to jail. But there's a catch, and the catch is that you have to be successful in your treatment. And if you are successful in your treatment, then I dismiss the case against you. 2 years ago, we expanded a little more, where now we do pretrial diversion for felons, nonviolent felons. You're not quite an addict yet, because I can't make that decision. I'm not qualified to do that. Instead, I have the folks who understand what's going on make those decisions. And if you're not an addict, I'll put you on pretrial diversion. You don't test dirty. You do what you need to do. I'll dismiss the case against you. Now, it doesn't mean that I'm letting people walk away, because if you don't do what you're supposed to do, then you're going to go to jail. Not because I want you to go to jail, but because I'd rather you be in jail than be dead. Last year, we had 58 people who died as a result of overdose. The year before, we had 59. The year before that, we had 60. At this time last year, 15 members of our community died as a result of overdose. You know how many we've had this year so far? 2. And that's not because of the work that I've done. That's frankly not because of the work that the recovery coaches have done. That's not because of the work that the doctors have done. That's not because of the work that the therapists have done. It's because of the work that all of us have done. And the most important thing that I've learned in the last 4 years is that I can no longer work in a silo. I have to work as a community. And if I can frankly sit in my office and eat bonbons, as opposed to prosecuting cases, that would be wonderful. One, because I like bonbons, but more importantly, because that means there are fewer and fewer and fewer people who are suffering that addiction. And if I can do anything, I will do that. If it means dismissing the case, I will do it. If it means you need to go to jail, I will do that. Last thing I'll say, because I see I have 30 seconds or here, the last thing I will say is our only inpatient drug program that we have in St. Joseph County is run by our sheriff. That's a travesty. We need a medical inpatient facility because I'd rather people go there than in jail. Thank you.
Thank you very much. And we do still have some seats in the middle. Those always fill less. So anybody standing, feel free to grab a seat and go right in. And anybody who's on the edge, if you want to, don't be shy. And next, we will hear from Kelley Gaffney.
Hi, my name is Kelley Gaffney, and I'm here to represent the Don't Punish Pain Rally organization. We're a grassroots movement. It's a national movement now that's formed in response to the over-pendulum swing of the opioid epidemic. First of all, let me say that I believe that we have to work with the addiction community. We're not on different sides of the fence. We may disagree about what prompts addiction to heroin and illicit fentanyl. But the reality is that there's 60 million chronic pain patients in this country. And every day they're dying and they're committing suicide because their pain medications are being taken away from them. Sometimes with no taper. They go to the doctor and the doctor tells them, sorry, we're not going to prescribe pain medication anymore. You're on your way. And they go out into the parking lot and they get in their vehicles and they blow their heads off. So this movement started not to take away from the addiction community. That's not what we're trying to do. We want our voices to be heard as well. We are chronically ill. We are intractable pain patients, chronic pain patients, injury victims that face a life of pain every day for the rest of our lives. And these medications, while they do cause problems for some, people who take it responsibly and work with their doctors accordingly are given life by these medications. I'm out of bed today because of these medications. These medications have helped people for thousands of years. I realize that I see all these faces and I realize that the addiction community is It breaks my heart for you guys, what you guys go through. I've had addiction in my family, and I've had death to addiction in my family. But we can no longer be ignored. And so the lady that started our organization lives in Rhode Island, and we have chapters in every state now. And we've had 3 rallies here in Indiana. We're having a 4th in May, and then we're rallying at the CDC in June. There's another pain patient that I just saw sneak in. It's not to take anything away from this community. Please know that. But we have a right to be treated. We have a right to live in as close to pain-free as possible. I have a bachelor's degree. I was a researcher. I worked for the Hudson Institute and the Indianapolis Metropolitan Police Department and the Indianapolis Police Department. And then I got sick. I was in a master's PhD program when I got sick, and that's a dream I had to let go. So I battled this for the last 15 years. And there's so many of us out there. And I have to mention a wonderful advocate that just died less than a month ago. Her name was Donnie Anderson. She was a double amputee with diabetes. She lived in Portage, and she couldn't get pain medication. Think about that just for a second. She couldn't get pain medication. And finally, her body gave out. She couldn't fight any longer. And she died. So we're here to make sure that you understand that there's another side to this opioid epidemic. People are suffering in our community too. You're not the only ones that are suffering and dying. But we have a right to be treated. We have a right to life. We have a right to be able to get out of bed every day and go to work. Some of us can no longer work. Take care of our children, our grandchildren, do our dishes, take a shower every day. We have that right. So please don't forget that there is another side to the addiction problem. And if you're interested in learning more about us, we've got a table out there. We have a website. It's don'tpunishpainrally.com. So, thanks.
Thank you, Kelley. Next, we will hear from William Horton.
Good evening, everybody. I go by Bill, by the way, and I don't have my glasses on, so I won't be able to see your indication for me to shut up. I'm just kidding. So I'm here on the panel that represents part of our community that often does not have a voice, and that's the children of our community, and that's the children of our community who have suffered from abuse and neglect. I work for the Department of Child Services. Excuse me. We have a table outside. I would invite you to visit that as well to get some information on how you can help that population as well. They are directly affected by the opioid epidemic in our community. They're one of the collateral damages of this problem. And as I said before, they don't always have a voice. Certainly they have a voice from their family and their relatives. But with dealing with this crisis of opioid and opioid use and misuse, families and parents don't have the energy or the time to address the needs of children, the basic needs of children. Oftentimes, those children are left to their own devices. And they end up in situations in which they cannot handle. They end up in abusive and neglectful situations in which my department has the first cause to deal with. But I'm here to tell you, just like this panel that's up here, we can't do that by ourselves. One of the things that DCS has learned over the years is that children thrive when they're at home, believe it or not. minus the abuse and neglect. They thrive in their communities in which they have lived and were born into. So obviously, the opioid epidemic affecting communities affects the ability for that to happen. And in order for us to make that right, we first have to understand the opioid epidemic, which I'm hoping we'll get out of this community forum tonight, and ongoing. And secondly, we have to have committed people willing to step up and help in those situations. And that's what we are asking, DCS is asking, that I'm asking as a community member for people to do. For one, to get the understanding from all sides. And we have a great panel up here that's giving us examples from different sides. And then to take into account the residual effects, the family members that go through the support of people going through this problem, and the children as well. So hopefully I invite you to our breakout session so we can talk about grassroots, what people can do in this room that can help this situation today. Not just for the opioid epidemic in our community, not just for those adults who are responsibly using opioids and being affected by it, not just by the addicts, but also by the children who need us, who are among the most vulnerable of us.
Thank you, Bill. It looks like we might have a few more people who have come in. Would you raise your hand if you have an empty seat by you? Okay, so we do have some in the center area. Feel free to come and take a seat. No need to stand on your feet. Don't be shy. Feel free to squeeze on through. I know some of you are volunteers who are standing. We will hear next from Brooke Marshall.
I suppose my story is a lot less dramatic. So I think what I chose to do for a living kind of speaks to my position. My name is Brooke Marshall. I'm a full-time addiction therapist at Oaklawn Psychiatric Center. I co-facilitate our intensive outpatient program. I staff with the Veterans Court and the Drug Court. I'm also the St. Joe County Jail Coordinator, so I coordinate our Vivitrol program here in St. Joe County. I also do the naloxone trainings here in St. Joe County as well, so I'm fortunate enough to be able to partner with quite a few of our community organizations. And I think that I hear everybody up here and their position, and one thing I think that I feel very fortunate is that we live in a community that partners really well. I think that we listen to each other, we listen to what still needs to be done. So I feel fortunate that we're able to partner with the health department, with criminal justice, with DCS, with the jail, and are able to hear each other out. So that's kind of my stance, and I'll make it brief.
Thank you very much, Brooke. And we hear next from Rodger Pinto.
Hello, I'm Rodger Pinto. I'm actually a student here at IU South Bend. I am working on my degree in political science as well as a candidate in the MPA program in governance. I have experience in this field, but I certainly wouldn't say I have much expertise. I spent about 7 years in the military in active service, and during that time I was a paratrooper and jumped out of a lot of planes, which brought along with it some injuries and brought me within the system of VA prescriptions when it comes to opioids. Towards the end of my service, I also served as a federal drug tester overseeing a group of drug testers as well as a substance abuse and addictions counselor in terms of the active duty side, which trust me is a lot different than what a lot of you are doing. But one of my biggest points in terms of substance abuse, specifically in the opioid side of things, is really how the structure and transition goes for active duty service members into the VA system. Their prescriptions and how they're structured in terms of the care they receive is very different on the active duty side. I like to equate it to the NFL's recent moves in terms of healthcare, right? You had doctors that were employed by a team to keep people on the field. On the active duty military side, especially during our long times of war, we like to keep our troops on the field. And a lot of times that's not necessarily the best thing for their long-term health and prescriptions, and it changes a lot when you transition into the VA system. So I'd be happy to take questions and speak to you a little bit about my experience on that. I'm glad to give them a
next from Dr. Rachel Schuster.
Hello everyone, so my name is Rachel Schuster. I recently completed my family medicine residency training here at Memorial Hospital in June. I'm also a part of the Masters of Public Affairs program here and will be finishing my degree just in a couple of weeks, so woohoo. But during this fellowship year is what my program calls it, I had the opportunity to be a part of a new program with our residency clinic. We work at the Blair Clinic, which is just right across the street from Memorial Hospital. And like I said, it's a residency clinic, so we're filled full of residents and our patient population is very diverse. We noticed about a year ago, we did a review of all of our patients and we had over 350 patients that were on pretty good doses of opioids. We recognize that yes, the problem is right here in our own clinic than here too. So I kind of broke it down into 3 reasons why we decided to start medication-assisted treatment at our Warner Clinic. So the first reason was internal. Like I said, we noticed that we had a fair number of patients that were receiving opioids, and we needed to look a little bit further into why they were receiving those doses of opioids. The second reason was external. So as we all know, right here in St. Joseph County, we do have quite the opioid epidemic. And being a part of this community, it was a way for us to reach out to our community and help. And then the third reason was just the call to family doctors. So as Dr. Gallagher said, there's a call to be compassionate towards people who do have an opioid addiction. And I think family medicine doctors like to pride themselves in saying that we're maybe one of the most compassionate groups of physicians. We go into family medicine because we like to talk to people. We like to know a little bit about everything. We like to know about your life, your children, your grandchildren. And so the New England Journal of Medicine actually said that the family medicine doctors were noted to be the necessary weapon to combat the opioid epidemic. We're great coordinators of care. Typically if you want a referral someplace, you're going to go to your family medicine doctor here first. And so we felt like we would be great coordinators of both your medical care as well as, if you are somebody who potentially has an opioid addiction, we could be great coordinators of that care as well too. And then kind of a piece off of that, as a residency clinic, we are charged with educating the future physicians. And right now, the opioid epidemic is a very hot topic. And we felt like this is an opportunity for us to teach the residents on the medical side of this treatment. And then those residents then can either use that knowledge down the road in their own private practices later on, or not. But at the very least, we've given them the opportunity to learn about that. So what we did, kind of just our model at our clinic, all of the faculty completed the necessary training in order to prescribe Suboxone or naltrexone. We don't prescribe methadone. That requires a licensed treatment program. That's not something that we do. So they all completed that necessary training to do that, to get that special licensure in order to prescribe Suboxone. We then created a medication-assisted treatment handbook where we went through, basically we had a presentation to all the residents and we distributed it to all the residents so that if they were interested in learning more about prescribing Suboxone, they had a handy handbook to look at. We opened it up to all the residents. It's not mandatory to prescribe Suboxone. However, anybody who's interested in it can do it. You don't have to have, the resident doesn't have to have their licensure in order to prescribe it, since the faculty member on that day can actually prescribe for them. So that's not a limitation. We also have a behavioral medicine team, which is made up of a licensed clinical social worker and then 2 clinical psychologists as well, who help with our intake process and help with the many social aspects that go along with prescribing Suboxone, as well as the important component of doing inpatient, outpatient, or intensive outpatient programs like with Oaklawn, which includes pretty intensive counseling as well. So all of us work together, kind of this whole teamwork theme that we've all talked about too, but within our clinic, to really try to provide the best care possible. Currently we have 12 active patients that we are prescribing Suboxone for. That's been starting in August of 2018. We have 5 residents that are prescribing and 3 faculty members that are prescribing. So we are all still actively learning as well too. I would not call myself an expert by any means, but I'm actively and eagerly learning more and more about this and look forward to learning from all my co-panelists as well.
Rachel, and thank you to all of you who are submitting your questions. We'll get those over to Dr. Gallagher now so he has a chance to look through all of those, and you will have one more opportunity while our next and final panelist is speaking to get those questions in. And so now we hear from Robin Vida.
Hi, thank you. As mentioned, my name is Robin Vida. I'm the Director of Health Education at our St. Joseph County Department of Health. And really when I was prepping my thoughts around tonight's conversation, really trying to think of the local, or the role of the local Department of Health. It really is at that macro level, or the outside of the larger picture, really looking at the issue around the opioid epidemic and substance abuse disorder. Really is multifaceted, and that's why there is a plethora of panelists here today, because everybody brings a piece of the puzzle. So we work a lot in building capacity for organizations and community partners that are doing phenomenal work, but they need a little bit of extra support. So whether that be through providing certified educators, or being a wheelhouse for information from the State Department of Health to come through, utilizing the local departments. We also look to connect people to treatment and recovery. And we do spend a fair amount of time at a primary prevention level. And when we think of primary prevention, a lot of times we think, okay, what's happening? How are we talking about it and getting people to become aware and not do this before they think that they might. And really when we look at that, our approach is to address trauma and adversity that ultimately impacts coping behaviors and mechanisms that ultimately lead to poor health outcomes. So we spend a lot of our time very, very upstream. So if anyone is familiar with an upstream-downstream metaphor, downstream, of course, is catching people when they already are now maybe potentially in treatment and recovery and potential relapse. We're looking very, very upstream. How do we look at policies and systems and environments that are encouraging and I guess high capacity, high functioning, self-healing, and allow for lots of different avenues to come in and address not just the opioid epidemic, but other public health crises as they unfortunately we know will develop, just as history kind of repeats itself.
Thank you. Thank you very much, Robin. This is a wonderful introduction. Now we're going to turn to your questions. And remember, if we didn't get to your question, or you felt like you wanted to ask your question one-on-one to the panelists, there will be an opportunity during those breakout sessions. And I want to thank Dr. Karen Rosso, the advisor to the MPA Student Association, for her tireless work preparing for this. She'll be one of the moderators of those breakout sessions. And Francisco Garcia, who is the president of the MPA Student Association, who will also moderate a session. And finally, my colleague, Jamie Smith, he will be moderating a session and teach both in our undergraduate and our graduate program. So now let's turn to your questions, and then you can continue that conversation with the breakouts. I'm going to turn it over now again to Dr. Gallagher.
Thank you all for your introductions, and I'm excited for this part. We will do our best, to get to everyone's question. But as Elizabeth said, we'll have breakout sessions, or we'll be available afterwards if you need to talk with us, even individually. So I'll go ahead and get started. This is a question for Alicia Brown, and the question is, what program or fellowship did you use in your recovery?
My initial recovery started with evidence-based treatment in the Department of Corrections, which was moral recognition therapy. We did some cognitive behavior therapy, but once I got out, I go to cognitive behavior therapy. I'm a huge fan of smart recovery, and I can't promote that enough. I would love to see some smart recovery groups in our area, but from the faith-based side, Celebrate Recovery is where I go. Thank you.
Are there any other panelists that want to comment on that or add to that? All right, thank you very much. next question, this will be for Robin, but of course, if anyone else has any information or insight, they can add to it. I may be paraphrasing a bit. A person has just received Narcan. What discharge education are they given upon leaving the hospital? And I understand, I mean, Narcan can be delivered in multiple settings, so of course you can comment on that.
Yeah.
And then there's a note underneath, I think a very important note, it says, are they told they are now 4 times more likely to fatally overdose within the next 24 hours? And just to clarify that question, the risk of overdose is not just for 24 hours. Just to clarify that, what I'm suspecting this question is about is they have received Narcan, therefore the opioids have been removed from their brain, from their neurotransmitters in the brain. Therefore, their tolerance may have decreased, which will then increase the risk for future overdose and death. So just to clarify that. So.
Correct, and I will look to Brooke as well as to Dr. Schuster to help, because I'm not as familiar what happens amongst discharge at the ER. Now, the Department of Health is the local distribution point for naloxone, so we work closely with Oaklawn and other community partners to ensure that they have the means to actually have doses of naloxone. Now, in the field, when naloxone is administered, we first call 911, and then administer the naloxone, and we are working with our local EMS to do some education on recovery breathing, since that's an extremely important piece to the puzzle. And then we stay with the individual until EMS arrives. EMS will take them to the hospital. In regards to the 4 times more likely to overdose within the next 24 hours, to Dr. Gallagher's point about the opioid receptors, also we are at times unsure of what somebody has overdosed on. So therefore, when we administer naloxone, it roughly will last about 45 to 57 minutes. Somebody could have taken something that is an extended release, so they may come to and be okay, and why we, I'm going to say require going to the ER in those cases, because they can overdose again if that drug re-releases until it's finally out of their system. What's that? Anything that you would, I'm not sure.
Yeah, I'm not sure what the exact protocol is in the emergency department. I know that I've seen like some, I don't know, protocols that they proposed. I'm not sure if those have actually been activated yet about, talking with the recovery coach and all of that. Okay, if anybody knows more about that.
I'll say, yeah, that's what I was just thinking, like the recovery coach piece. Yeah. So I don't know about every ER, but I do know about Memorial ER. Memorial ER, if somebody goes in as an overdose, Oaklawn has partnered quite nicely with physicians through Beacon. And so what we do is a peer recovery specialist is contacted, and if that physician chooses to contact a peer recovery specialist, they can come in and actually do an assessment and get them linked up with services right there. And they also have the option of getting a physician who can prescribe them buprenorphine or Suboxone. So we're coming a lot longer than what we, or a lot further along than what we used to be in the ER. So I think that those services, and those are brand new services, they're pretty fresh within like the last probably 6 months. Maybe, yeah, about 6 months to a year. So that's what we're doing in the Memorial ER.
Thank you all very much. One thing I just want to comment briefly with Narcan. It is a very positive thing that we have lots of Narcan in our community. And the positive aspect of it is that we are saving lives. But with any complex issue, such as this, any social issue, there are pros and cons. And one of the cons that we need to be candidly open and honest about having so much Narcan in the community, the positive is it's saving lives. But the con is that the person may be revived at home. They may get revived and then return right to using drugs. So we've saved the life. So in no way would I ever suggest that we should stop giving Narcan out. I'm not, just so we're clear. We absolutely should continue because it saves lives. But that is different than someone who overdoses and goes to a hospital, is revived, and then they're provided with services, where we can get them into treatment. And so I think it was an excellent question, great comments about, I mean, these issues are very complex, and I think it's a service to everyone here to be very candid and honest about, the pros and cons of all these strategies. Next question is for Bill, and I actually got 3 of them, so they're all pretty much the same. It says, please explain some of the services DCS offers to people and kids struggling with opioid addiction.
So DCS doesn't have any services on site. All of our services are through private or contracted state services that are in the community. That's one of the reasons why we've changed our focus from not so much removal or even removal out of the community, but to keep families, keep children in the community, service families in their community, and utilize the resources that exist. A lot of the services and resources that we use to help families treat opioid addictions, either parents or children or both, are community resources that they could have accessed without us being there. The community resources, the community mental health centers, therapeutic services. All of those we contract with them to use, and we refer clients, children, and parents to those services. We monitor them and we pay for them. Sometimes the court is involved, and the court will monitor them. But it's really no secret. And it's really we don't have a secret service connection anymore. We don't have therapists on our sites, in our offices, that we even hire. But we utilize community services, and we encourage that. There's a good reason for that, because that way they can continue those services after I'm involved, so that they can help themselves. I see you now.
Thank you, Bill. Anyone else have any thoughts or comments on that?
I wanted to ask some of the other panelists a quick question. I've not heard the words heroin, illicit fentanyl, cocaine, methamphetamine. I've not heard those words. Everyone says opioid epidemic, and the first thing they think of is pills. I mean, I think everybody's guilty of your sign has a pill bottle on it when you talk about the opioid epidemic. What's the case here in your county? I live in Indianapolis. I'm from Marion County.
That's a fair question.
I've not heard heroin, illicit fentanyl.
So I can speak on the treatment providers part of it, that opioids, when we say opioid, it tends to encompass, sorry, I'm and I don't even know my word. I speak to IOP all the time. When I utilize the word opiate, I guess I can't speak for everybody, we encompass all the above. So certainly not cocaine or methamphetamine, that's not an opiate. But pills, fentanyl, and heroin, all the above. So as a treatment provider, I see all the above come in to seek treatment. So I wouldn't say like one person is addicted to heroin or fentanyl. I would just say that they have an opioid use disorder, right? So when I use the word opiate, it kind of encompasses all of it.
Yeah, and prescriptions, up until last year, prescriptions were the #1 cause of overdose deaths in St. Joseph County. I know that for a fact. I know that for a fact. Up until last year, it was the #1 cause of overdose deaths. Last year, it was a combination of heroin and fentanyl. Our trend has gone from prescriptions, roughly 70% up until last year, were prescription involvement. They are now roughly 70% heroin and fentanyl. So when I say opioids, I don't think of pills. I think of that actual drug itself, whether it's heroin, fentanyl,
Right.
carfentanil, or
Right.
prescriptions.
Well, and I guess that's my point as well. Prescribing for these medications is down, and overdoses continue to increase.
So, to answer your question from my perspective, I say opioid disorder because that's the addiction that I had, so I speak from that. But I fight for anyone that's got any type of an addiction. At Choices Recovery, we see everything from marijuana, alcohol, heroin, fentanyl, methamphetamine, you name it, we see it. I think it's just an overall term that's being used because unfortunately you say crack, you don't get the same attention as you say opioid. That's just a common, that's just what it is. And that's unfair and that's wrong, but unfortunately if it takes, and unfortunately it has taken this word to get the attention of the people we need it to, I'll scream whatever you want me to scream.
Thank you all very much. The next question is going to be for Rodger. Rodger, could you explain to us just some of the unique challenges that veterans may face in treatment, in addiction, and seeking recovery?
Absolutely. So I would say the challenges really start in the active service level, because the conversation about prescription painkillers does not have an active service. You know, we do a lot of briefings on illicit drug use, but recent numbers show that about 25% of active duty service members over the course of the year are prescribed opioids. So we're giving these briefings to our soldiers, but at the same time we're not talking about probably the biggest elephant in the room, which is 25% of the people sitting there will be on opioids at some point during that calendar year. We're not having that conversation with them about what should you be aware of in taking this medication. It might be happening at the provider level, but it needs to be brought to that line unit level, that battalion level, where all of our soldiers are hearing those things. And I speak from an Army perspective, but this is across all of our branches. It's not something that's discussed publicly and out in the open, and it's something that really has to be. Because if they have a chronic pain condition, and speaking from a veteran's perspective, a lot of that is the prescription. That's what funnels us in. It's a lot like Prosecutor Cotter mentioned earlier. Athletes, this starts at a certain type of level for a lot of people. On the military side of the house, it typically starts with service-related injuries. And when we're moving into a transition I'm running out of time. If we're moving into a transition in the VA side of things, what we need to look at is focusing on how those prescriptions translate from active duty service, which is a completely different healthcare system from the VA, and ensuring that those support mechanisms are there for treatment, and cycling people off of those medications or finding the pain treatment plans for them moving forward.
Thank you, Rodger. The next question I'm going to open up, so whoever wants to take the lead on this, and I think it's a great question. How do we limit doctor shopping? Addicts going to the emergency rooms or several doctors to find, the substance over and over again? And perhaps one of y'all could talk about the inspect reports. I believe they're still called that. Yep, so I'm going to open it up to the whole panel.
We use them too.
Yeah, so Indiana has something called Inspect that all of us physicians have access to, and so what we do is just put in the patient's name and date of birth, and we can look and see how many prescriptions, and these are controlled substance prescriptions they've had. I think it goes back like 2 years actually, so that's an easy way for us to see who has prescribed the medication recently. Are they really out of their medication, or should they have still some tablets left? So that's probably the quickest and the easiest method that we have for trying to prevent doctor shopping.
From someone who did this, I can honestly tell you those inspect reports don't keep you from doing it. From the doctor's perspective, great, but we live on the border, and I'm telling you this because I have charges in Michigan, Elkhart County, and St. Joe County, that it does not keep you. So what will hinder the doctor shopping is more education to people in the surrounding areas, to the people who are suffering with addiction, getting them into actual treatment when a doctor sees on the inspect report that something's going on. What has been happening, and in my personal experience, I had doctors that saw on the inspect report that I was misusing medication. And the stigma of having that conversation with me, I can tell you, out of maybe 85 doctors, 5 took the lead. And of course I wasn't ready and I didn't listen, but I think what Dr. Schuster is doing now is amazing. She is bringing awareness to her residents, to the new doctors to have the conversation.
think also you have to remember that chronic pain patients, we have to sign pain contracts with our doctors. We have to agree to have urine tests. Some of those are very invasive. I've heard stories of women who had to take urine tests with the door open while the nurse watches. So there are ways to avoid the doctor shopping, but we're ultimately paying a very serious price for that. Of course, it has to be reined in, and the Inspect database is a great way for that to happen. You know, the reality is that there were pill mills, and the DEA, rightfully so, shut them down. And the reality is that people will try to doctor shop to try to get pain medications. That is a reality. But I think a lot of that has been reined in. But unfortunately, we have to pay that price as well.
Yeah, I have two comments. One is, just so it is crystal clear, at least from those of us who are sitting here, the issue of addiction and opioids is not from the chronic pain sufferers. Frankly, our pain specialists have done a pretty darn good job, even before this became an epidemic, in monitoring the chronic pain sufferers. I'm not talking about those who acted like they were chronic pain sufferers. I'm not talking about those who went from doctor to doctor, as you heard about. Most of our overdose deaths for prescriptions in years past and even today, the person who overdosed did not overdose on their own prescription.
Exactly.
They got the drug from their aunt, their grandma that was sitting in the cabinet, their neighbor. They bought it on the street. That's where they got those. So I just want to make sure, because I think that maybe sometimes there's a misunderstanding. Those who are getting a lot of pain medication because they are a chronic pain sufferer, I'm not a doctor. If the doctor has said that they need it, then gosh darn it, they need it. Those are not the people that are the problem. The people that are the problem are the malingerers that a doctor isn't paying attention to, or those who are buying it and diverting it and selling it on the street for money for themselves. That's where I see it from the criminal justice system.
I want to make a brief comment because we're kind of in the same field with this question. And that's to do with our prescription drug monitoring programs here, which is what we're discussing. And recently, the numbers haven't really quite come to fruition yet, but they've been moving in a positive trend. The VA passed a prescription drug data accountability act in 2017. So what that did was require that the VA take opioid prescriptions and put them at the state level drug monitoring programs. Because one of the issues we've seen in the veterans community side of things is dual prescriptions. About half of the veterans enrolled in the veteran healthcare system also get Medicare Part D. So they're able to get prescription access through two different systems that until recently hadn't been reporting to each other. So I think looking at some of those systems and working on them to make sure we are getting the information about prescriptions available across all of those systems makes a big difference in the long run.
Thank you all for that very comprehensive answer. One thing just to add with the inspector reports is that they also monitor benzodiazepines, anti-anxiety medications such as Xanax. So it's not just related to opioids. And stimulants like Adderall, amphetamine salts. And that's particularly important to know because the combination of a benzodiazepine, Xanax, with heroin is what's lethal. 80%, and this is a report from our government recently, of the overdose deaths is where heroin or other opioid is combined with fentanyl or a similar synthetic opioid. Or we see opioids such as heroin combined with a benzodiazepine. They call it additive effect. 1 + 1 equals not 2, 1 + 1 equals 5. So these inspect reports are a part of the solution. The inspect reports and the other strategies that were discussed here, they're certainly going to minimize the problem. But with minimizing the problem, there are going to be a handful where it doesn't work. It's not effective. They will most likely either die, unfortunately, or best, get arrested and get involved in the criminal justice system. And whereas Ken, and we have a good, strong representation here, it's positive to see that the criminal justice system is approaching this through a rehabilitative lens as compared to a punitive lens. And again, I just think that's providing kind of the pros and cons, a really candid perspective on this complex issue. Next, this is for Ken. It says, what steps are being taken in our county that you're aware of to get an inpatient medical treatment program?
Great question. I can tell you 4 years ago, when I first started as the elected, we met with representatives from our senators, we met with representatives from Congress, I see Becky Savage, I didn't know you were here, Becky. We met with Becky Savage in the 525 Foundation that has done fantastic work. I'll meet with anybody, I'll talk with anybody, I'll beg with anybody. I can't sell my house because my wife wouldn't let me, but other than that, I would do anything I can to get that because I firmly believe that that is the #1 need in St. Joseph County. We have more people die from overdoses than we do homicides and fatal crashes combined. That's ridiculous because this is preventable. It's preventable instead of having 14 attempts until the 14th hit. Get it the first time, and I don't know enough. And frankly, Bill Redmond, our sheriff, he's a cop. He's not a social worker, and he's not a doctor. He should be. I want doctors to be able to run this, and doctors want to. We just don't have the facility. I'd rather have them go there than go to jail. I don't know if anybody else knows how we can make this happen, but it needs to happen.
Aren't the federal grants available? Oh, Lord.
Not to talk about grants, but I can tell you that we have an excellent facility here in St. Joseph, and that's Choices Recovery. And for those of you who haven't had the opportunity to meet the executive director there, it's an amazing program. It is private insurance. It's costly, and that's where we run into the issue, because there are people that don't have health insurance, and that stinks, because those are the people who are calling me at 2 o'clock in the morning that I'm trying to find them on a SAMHSA website, getting them into somewhere. Because there's nobody that will call me for treatment that I won't help.
Most doctors don't have insurance.
That's what I'm saying, yeah, and that's why I try to work through the SAMHSA website. I try to find a place. I do know of places in Indiana that can take you, but we're talking about, I do want to at least know that we do have a good recovery place in St. Joseph County. There's a lady holding her hand up. Is that, go ahead. It's not my show, but go ahead.
My name is Linda Rowley. Yes. I'm a pain patient, but I also work with addicts.
Wonderful. Thank you for your service.
Thank you. One of the problems that I see is if we're dealing with addicts, first of all, the percentage rate is very low for people that actually do want help. But when they do, then we should have more programs available to them. Number one, they burn all their bridges.
Yeah.
So they don't have family, they have no money, and I literally have to drive 3 hours to get somebody into a detox program because there's nothing around here.
Yeah.
But can I kind of join my question together, all of you? I have a few questions actually.
If I can just stop.
Again, not my show. Here you go.
We are going to move on. We're recording this, so you can't be heard because you don't have a microphone. And if you do have a question, please just write them down, pass them over, and then we'll put them up here.
I did, but you have my card.
Okay, so I will work my best to make sure I get it. And I hope that that's okay. I certainly don't want to create a forum where we're having a dialogue this way. And there's people in the other room. We have an overflow room that wouldn't be able to hear that. So we'll stick with this structure, please. So the one thing I want to comment on, though, with this is we do know that when someone is motivated for change is when we want to get them into treatment because there's a more likelihood of success. And by success, sustained recovery. Think about it if you ever got pulled over for speeding. I remember I get pulled over for speeding, I say, whew, I better slow down. I'm really motivated right after that consequence. And maybe 5 minutes, 10 minutes later, the next day I'm back driving in my normal routine. Okay? Now certainly speeding and addiction are apples and oranges, right? But we do know that motivation is key, right? But it's not always necessary, right? We know that coercive treatment can say you either go to jail or you go to drug court, works. Not only does it work, drug court, so coercive treatment, men and women who are not motivated to change whatsoever. Not only do drug courts work, they are the most evaluated criminal justice program ever. And we have evidence for almost 30 years that they work. And by work, to be clear, there's recovery, so reductions in drug use or abstinence, and then most importantly, they stay out of the criminal justice system. So motivation is key, right? But it's not always necessary, right? It's not about why you enter treatment. It's what happens when you enter treatment.
John, real quick.
Yes.
Again, speaking for that population that can't speak for themselves, when we talk about the children affected by this process, and we talk about motivation, children are a motivation for treatment. But even if that motivation is not there, those children still need closure and permanency for themselves. And we have parents who are addicted, who obviously need inpatient treatment and don't have access to it. And when they don't have access to it, then we don't have access to bringing closure to that family case. So one of the things that you all can do is advocate to the political representatives in your district and let them know, because this is an issue that doesn't get a lot of publicity in the political realm. You know, not a lot of people want to hear about the needs of addicts. That's just the truth of the matter. But a lot of people don't look at the collateral damage that exists in that. So I would invite you to talk to your congressman, write your senator, your congressman, tell them we need those services in this area. We need that inpatient service in order for that to happen.
Besides the collateral damage, that's such a terrible term for children. Besides the damage to the children, if you don't have kids, you don't care about kids, then think of this point. 85% of all of our property crimes committed, not just in St. Joseph County, but in the United States, are committed by folks who are addicts. I'm going to say that again. 85% of all of our property crimes, the thefts from Walmart, somebody breaking into your house, the robberies, all of those, 85% of them are committed by those who are addicted or those who need money to be able to help somebody who is addicted. So for just mercenary reasons, we ought to be working on recovery and rehabilitation as opposed to just, let's put them in jail for a couple of months and then let's let them out. Because otherwise, we're just going to go back to having more and more people die and fewer kids who are getting the upraising that we all expect by mother and father, by people who love them. Because the addict is loving that addiction more than their kids. It doesn't make them a bad person. It makes that addiction that powerful. So let's break that chain.
Something really quick. I just want to specify that 85% of crime that's happening is happening for individuals in active addiction, not recovery. So the people that are living in, no, that's okay. Hey, I'm learning this. This is going well. Active addiction is where the crime comes in. People who are living in recovery have already been through an inpatient rehab program. They're on the right track. They're motivated, completely different.
So I'm going to piggyback a little bit on Dr. Gallagher. So I do our intensive outpatient program at Oaklawn. And so I think it's interesting. So these are people to meet criteria for intensive outpatient. That's about 9 hours a week. So I spend a substantial amount of time with them. And you have to have moderate to severe substance use disorder. And I think it's important that we start learning the language behind that because addict is a rough word. So substance users, right? That are coming in for treatment. So if you, I recently actually asked how many people were involved in the criminal justice system. Quite a few. How many people enjoyed being involved in the criminal justice system? No. Unanimously no. How many people are thankful they're in it? Unanimously yes. All of them said if I did not get arrested, I would have had no idea where to start. I would have not had the resources available to me. I wouldn't have gotten clean long enough to even want it. So I think it was really powerful for me to learn that too because I'm all about motivation. But the motivating factor for these people was the ability to have those resources available to them. So I think it's important to understand that side of it too, is most of the people who are involved in, not all, most of the people that are involved in the criminal justice system are actually say that saved their life.
Thank you all. Next question, and I'm going to open this up to anyone. I think it's a very important topic. How would you suggest to help these community members when they come to us for help without enabling? So to kind of paraphrase that, I assume this question is, how are you going to help family members? So not those that are addicted, but those that are impacted by their loved one's addiction. What resources do we have? What suggestions do you have for our audience?
How are you going to help the family or help the family get them?
Family member wants to know, how do I help that addict?
What advice do you have for family members who've been impacted by addiction? Let's keep it like that.
Oh, okay.
Yeah.
I'll take this one.
I wish my family would have done tough love a lot sooner. My family meant well. They loved me. They didn't want to see me suffer. And yet, I'm recently learning the ripple effects of what I did to them made them suffer. What you can do for your loved one, get them help, get them into treatment, call somebody, get on the Samsha website, call me. My card's up there. You can call me anytime, day or night. My phone is on. It drives my family crazy, but it's on. Don't enable. Don't give them money. Don't pay their bills, because what's going to happen, you're afraid they're going to turn to the streets. They're turning to the streets already. You just don't know it. And that's just something from my perspective, what I wish my family would have done. And I know, I will put this briefly, my dad was my best friend. He was my dad, of course, but I loved him. And I missed coming home for his funeral by 6 months. And that's something that I have to live with. And I know that that man did not want to see me suffer. But in turn, that's the hand we've been dealt.
Brooke, maybe if you could comment on the family program that we do at Oaklawn? The intensive outpatient program?
Yes, we do now. No, we do. The intensive outpatient program, I think what he's referring to, we have every Thursday, and our program is Monday, Tuesday, Thursday. So every Thursday, we have a morning intensive outpatient program, an evening intensive outpatient program. We also have an all-women's matrix IMP. So we have quite a lot, and those are just 3 of the sub-groups. But those 3, we have what's called Family Day, and so they can bring in a spouse, a loved one, a friend, even if they're actively using, as long as they're not in treatment under the influence, so they would, trigger anybody else in the group, because we have to think of their well-being. As long as that doesn't happen, they're welcome to bring anybody that they like. The only thing I think that we deter a little bit is kids, just because of the topics that can come up. Sometimes that's not always healthy for a young child to be at. I'm going to side note it a little bit. So my disclaimer a little bit with opiates, I think sometimes we forget opiates are very unique in the fact that you gain tolerance and lose tolerance very, very quickly. So your risk of overdose happens within like 72 hours of no use. So I'll often have parents say, well, I just want to drop them off at a detox facility and let them detox and figure it out. But the truth is, if they stop using and you don't have an active plan for when they come out and they start using again, we put them at a huge risk to overdose. So as a treatment provider, let me be clear, until somebody is ready to get that help, you're not doing anything wrong. That person has to choose to get that help, right? Like they're going to have to choose to be ready and make changes in their life.
I wanted to say one thing. What does a family member do? I think of 3 words. One is honesty, and by honesty I mean that 1, you don't lie for them, you don't cover for them, and 2, you are honest with them when you see that they're doing something that you know is not right, and don't just fall into the belief or acceptance of the lies that they're telling them. Second is tenacity. That means you don't give up on them. Now, it doesn't mean you give in, but you don't give up on them. You don't just say, hit the street. You may say, I can't have you live here anymore because you keep stealing from me, but it doesn't mean that you give up on them. Tenacity. And then the third one is compassion. Compassion means that you care about what's happening to them, but it also doesn't mean that you just excuse it. That's not compassion, that's enabling, that is giving in. So those three words those family members have, I think you go a long way. Oh, I have to give one example. I just charged a case today. Son continued to use, steal. She tried to kick him out. He would break in through the window. The police officers would come there, but because he lived there, he had some property rights there to be able to still live there. He took his sister's phone, stole it, and was going to pawn it. They tracked it down. The officers smartly saw that, arrested him for that theft because he had the phone, and of course he had the drugs on him. Now he's in jail, and hopefully now our sheriff is going to get good treatment for him so that maybe he can get on that road to recovery.
Thank you all. And of course, if you have any questions, we'd be willing to meet with you individually, and then we have our breakout sessions. Unfortunately, we weren't able to get to every question, but we'll be available to meet your needs. One thing I do want to comment on, and I'll just kind of use this as my closing comments, there were several cards and several questions related to economic and racial oppression as it relates to addiction and the opioid crisis. I've been more than happy. I've written several journal articles on this work. My work and research is related to addiction as it intersects with African American studies. But I will give a specific example. When we're talking about racial oppression, we're also talking about the intersect of racial and economic oppression. A study I came across recently said we're making progress with the opioid epidemic for two reasons. Number one, there are fewer ER visits for overdoses. Number two, doctors are prescribing fewer opiates. I would take both of those benchmarks with a bit of caution. Number one, there's fewer ER visits because of overdoses. Well, we talked earlier, one of the reasons may be there's still lots of overdoses, but they're being treated with Narcan in the community. The benefit of that is they're alive. The downside of that is they're not getting the resources that we may be able to give at memorials such as recovery coaches or simply a referral to treatment. Doctors are prescribing less opioids. That doesn't mean that people are using less opioids. I can speak for this, I know Brooke and maybe others, and I'm sure Ken has seen too, that how, and I'm Dr. Gallagher, but my daughters remind me you're not a real doctor, is what they tell me. My daughter said we would live in a bigger house. That is true. I'm a PhD doctor. So I'm not going to pretend to know the world of physicians, because I don't. Someone like Rachel is trained in this, okay? But I don't know the training for all physicians, and it's about how they're titrating folks off of the opioids. Because if they're not doing it appropriately, those with pain are going to seek, as they say, the streets. They're going to get the drug illegally. Why? Because they're in pain, and they want to improve the quality of their life. Here's the economic oppression. And the economic oppression, we know this historically, right, through many crises in our country, is connected with racial oppression. What we don't always want is physicians saying, there's alternatives to opioids. Why don't you try physical therapy? Well, opioids may cost, and I've seen it, I've seen people get a month's supply of Norco, Vicodin, for 80 cents. And they took it as prescribed and helped treat their pain. The cost of physical therapy may be, with the high deductible plans we have now, $1,000 to $1,500 a month. 80 cents, $1, $2, $5, $20, $1,500 a month. When we say, do the alternative to the medication, that is the projection of upper middle class affluent economic values onto the poor, onto those that can't afford it. And again, as I shared with you earlier, and I saw in these questions, I would feel remiss if I didn't acknowledge it, and some did. I'd be more than happy to meet with you individually or in the breakout session, right? I am very proud of the work we're doing in this community, right? Because we're saving lives. Do we have far to go? Absolutely. Are we saving enough? No. But we have to be real and candid about, here's what's working, let's talk a lot about it. And here's where we're failing. And the economic oppression example I just gave about, hey, try acupuncture, try physical therapy instead of the pain medications, right, is a problem. Do I have the solution? No. But we need to be candid and honest about the problem first before we can seek that solution. So I do look forward to seeing some of you in the breakout session. I'll be here all evening and look forward to having a conversation. I'm going to pass it on to Elizabeth now.
Thank you very much, John. We have our breakout sessions on the back of your program. You can see the room and the title and the panelists who will be there. And you will see that Sheriff Redmond will be joining in those breakout sessions as well. And I just have a few more people to give, well, it will take 1 minute collectively. We talked about public policy and elected officials. We know there are a couple of elected officials, Ken Cotter and Bill Redmond, of course, that both serve in elected positions. There are a few other people here either serving or running for elected office. Just your name and office. Please, if you want to stand so people can talk to you as we're mingling and looking at our resource tables and enjoying our refreshments, or during the breakouts. Just stand.
Sue Custom, I'm running for council ward.
Common Council of South Bend.
Amanda Govert-Conrath, I'm running in the 2nd District City Council, but I wasn't here for that, so it's not about politics, but if you do want to talk to me, I'll listen.
Anybody else here? Okay, all right, terrific. And please look at those wonderful resource tables. We do also have some refreshments in room 1125. And then pick a breakout. We'll have about 20 minutes in the breakout, and then you can pick a second topic as well.